All right, starting us off on week 8 is going to be the identification of restorations, dental materials, and foreign objects. This is in chapter 32, and it starts on page 381 in your book. The learning objectives for this chapter will be to define the key terms associated with identifying restorations, materials, and foreign objects on dental images. We will discuss the importance of interpreting dental images while the patient is present. And on dental images, identify and describe the appearance of the following restorations: amalgam, gold, stainless steel and chrome, post and core, porcelain, porcelain fused to metal, composite, and acrylic. On dental images, identify and describe the appearance of the following: base materials, metallic pins, gutta percha, silver points, complete dentures, removable partial dentures, orthodontic bands, brackets and wires, fixed orthodontic retainers, dental implants, bone grafts, suture wires, metal splints and plates, bone screws and stabilizing arches. And on dental images, identify and describe the appearance of the following: earrings, necklaces, nose jewelry, eyeglasses, patient napkin chains, hearing aids, shrapnel, and other miscellaneous objects. So, why are we doing this chapter? Well, we need to review those common restorations, the things we're going to see, the different types of dental materials and how they show up on our radiographs. And we need to be able to identify foreign objects that can be seen on dental images. We'll go over the most common foreign objects, but we'll also look at maybe some of the thinking process that goes into what that object might be, if you don't know what it is, if it's not one of the common ones. And then the dental professional should interpret all dental images while the patient is present. This is important because we want our patients to be able to say, if maybe we thought it was an amalgam tattoo, but it's actually shrapnel, and the patient has this, history, this like patient history, social history, those are all things that we need to take into account when we are trying to interpret, or when the dentist is trying to diagnose those images. And so it's important that the patient is there to provide that medical and social history while we're doing this. So when dental images are interpreted without the patient, sometimes that important clinical information is not available. So the first thing we need to identify are the restorations, the stuff that the dentist is putting in their mouth, right? And those are going to include the amalgam restorations, gold restorations, stainless steel and chrome crown restorations, which we mostly see on kiddos, post and core restorations, porcelain restorations, composite restorations, and acrylic restorations. So in the very important, trying to figure out what these things are made of, right? What they are. The first step is metallic restorations. And a metallic restoration is the most dense thing we're going to put into someone's mouth, right? And we know that if it is very dense or the most dense, then it's going to show up the most radiopaque, right? Because it is so dense, when the x-rays travel to go to the receptor, the metal will actually absorb it, and it won't allow the x-rays to penetrate through and get to the receptor, which means it won't energize those crystals and it won't turn black. So in those areas where it is bright, bright white, that is metal. So very little restoration comes in contact with the receptor. That area of the receptor remains unexposed, and the metallic restorations appear completely radiopaque on a dental image. Non-metallic restorations are a little bit different. They are very different. Each type of material is different. They're not all going to look the same. So they vary in their density, right? So some of are very dense, and some of them are not as dense. And so some of them will come in very radiopaque, pretty close to metal, but then some of them will come in pretty radiolucent, and they'll look almost darker than the tooth. And it just depends on the type of material you're using. Your book likes to highlight at this point that porcelain is the most dense and therefore is more radiopaque, right? So it's the least radiolucent. And then acrylic is the least dense and therefore is the most radiolucent. That just says porcelain is the most dense, so it is the most white. It's not dark. And then acrylic is the least dense, so it is the most dark of the non-metal restorations. So we're going to get into amalgam specifically because amalgam is one of the most common restorations that have been used in dentistry. It's not the number one most commonly placed filling today. We've sort of shifted away from it a little bit because of the metal that when patients open their mouth, they don't like the way that metal looks. There's also a lot of other factors that go into maybe why we wouldn't use amalgam anymore, but that's for a different class. As far as here in radiology, amalgam is one of the most common um, filling materials that have been used. And we're going to go through the one surface amalgam restorations, what those what those overhangs look like, and what the fragments look like. So, amalgam restorations. So, on a one surface, oh man, you try writing with a mouse. So these appear as distinct, small, round, or ovoid radiopacities. They can typically be seen on the buccal, the lingual, or the occlusal surfaces. I don't know about you guys, but I have a buccal amalgam pit filling on one of my molars. So you might want to take a look inside your mouth and see what you got. But on a radiograph, they look like this, just these perfect sort of round or ovoid, they're pretty small shapes. It looks like this on a fake tooth. This is what an amalgam filling looks like. Um, on a larger two-surface or a multi-surface amalgam filling, then they're going to appear radiopaque, just like always, this super bright white, and they are characterized by irregular outlines or borders. So you can see this very wonky shape here at the bottom. That tells us that this is an amalgam filling. It's not a crown, it's an amalgam restoration, amalgam filling, because it is so weird shaped. An amalgam overhang, this you might also see on your boards, is an extension of amalgam seen beyond the crown portion of a tooth in the interproximal region. It will disrupt the natural cleansing contours of the tooth, it'll trap food and plaque, and it will contribute to bone loss. Amalgam overhangs are a very important aspect of dental hygiene, and being able to see where those overhangs are and explain it to your patient and point them out for your dentist are an important aspect of being a hygienist and doing the best thing you can for your patients. So you need to let them know that if their dentist placed this filling and they didn't contour it well to the tooth, then it's doing them a disservice. It's actually harming the tissues around that filling. When a dentist does an like a interproximal surface tooth, they have to place this band around the tooth. And then they place a little wedge in between the teeth in order to get the band completely up against the tooth and to make the filling material that they place in there the shape that the tooth was before, before they drilled it away. And it's important that they get it perfectly flush with the tooth. They get it completely up against it so that there's no little sort of blip hanging off the side of the tooth. You can see this on page 383. It's on figure 32-7. That number 4 at the top, you can see how it's that white filling sort of sticks out the side. That is an amalgam overhang. Now, overhangs can be made of other types of material too. We can do it with both composite and sometimes a crown. The margin won't be it won't be perfectly flush up, and it will cause the same problems as this. Amalgam was a little bit more common that we see these filling materials have this problem because of how prevalent the material was. They were using it a lot, but also because amalgam is very time sensitive. It cures very quickly, and so a dentist doesn't have a lot of time from the time that the amalgam is fixed or it's mixed, sorry, to the amount of time that they have to get it into that tooth. They don't have a lot of time, and so they make mistakes, and then once they notice the mistake, instead of drilling out that filling that they just placed, they just leave it. And sometimes they don't even know. Sometimes they take it out, they think it looks good, the patient leaves, and we don't find out until the next time they take radiographs that there is actually an overhang there. And so It's something to be aware of, and it's something to know what you're looking at when you see an amalgam overhang. So this is what that looks like in your book. It's on the page I told you about from the last chapter. So the amalgam overhang looks like this on a tooth where they placed it. And when they do, they're supposed to, hold on, let me get rid of this line. They're supposed to place a band around the tooth that would like perfectly curve this tooth together. And then they stick like a little wedge here and it will hold the band right up tight against the tooth so that we have this perfect curved line. The shape of teeth is very important as to their function because if we don't have that curve along the side of the tooth that narrows down, when you eat food, it comes down into this area and it gets caught in this space down here, and we don't want that. So this curve of the tooth is very important to having that function of one, trying to keep the teeth clean, but also like not getting food caught around it. And so when you have an amalgam overhang like this, then you're getting food stuck all in this area. All of this food gets trapped here. That bacteria grows. It causes bone loss. It can cause all sorts of inflammation. It can cause pain, and it can also cause um, another cavity to form right underneath this area here because food is getting caught here, plaque is getting caught here, and it's going to cause recurrent decay. And this is the area that we're talking about on this one. You can see this area up here where that overhang is sticking out on the side of the tooth. Amalgam fragments are when an amalgam filling is being placed or it's being removed. Sometimes little pieces of the amalgam itself will flake off, or if you're removing it, you're using a drill, and so you get that like sort of dust that the drill will form as it's, drilling away at the metal filling, right? And so sometimes that dust will get onto the tissue, or sometimes a little piece of the metal filling will actually break off and will become embedded in that soft tissue. And it looks like this when you see it in the soft tissue. This is called an amalgam tattoo. I'm sure you've seen this in some of your other classes, but that is what that looks like. It's going to be more of a blue, or sometimes in patients it's kind of a purple hue to it. It's very different from melanin, right? When we talk about melanin variations in our patients, we're talking about, that naturally occurring color to certain tissue, like certain areas of the mouth. So when we see melanin, it's going to come up brown, or sometimes it's even like a tan kind of color. But when we talk about amalgam fragments, we're talking about a blue or a purple. So they're very easy to tell the difference between a melanin or amalgam. Okay, when we see this on a radiopaque, when we see it on an x-ray, it's going to appear radiopaque, and it's going to appear kind of like sort of like there might be a little bit of dust on the screen. So this is what those, amalgam fragments look like. A little piece of the amalgam has broken off and is now embedded. It says soft tissue, but this is actually embedded in the bone here, so it's not, it's a drawing. And this is what it looks like on your radiograph. Now, typically this is not embedded in the bone, even though it looks like it is. This is the soft tissue around the bone. And what happens is usually there was either another tooth that had a restoration, or maybe it was even this one. Maybe that they don't usually do amalgam fillings on anterior teeth, but you never know. So maybe this was an amalgam filling before, and when they replaced it in order to put this composite filling here, some of that amalgam actually, kind of flung off and was absorbed by this tissue here. And so then we see this. If we were to look inside this person's mouth, we would be able to see kind of an amalgam tattoo, or a big blue purpley sort of blotch right here. Gold restorations appear completely radiopaque, just like the amalgam or the metal, right? And unlike amalgam restorations, they are a perfect, smooth marginal outline. For gold crowns or gold bridges, they'll appear as large radiopaque restorations with smooth contours and irregular borders. Gold foil restorations are a little bit different. They were not typically done very often because it was such an expensive material. Amalgam was better. Although gold is one of the best materials we can place in someone's mouth because it is more malleable. It's a softer metal. And so, as the patient bites or grinds or whatever happens to it, gold is much more forgiving, and it doesn't break or chip quite as well, or quite as much as metal or porcelain does. So it's a really wonderful mouth restoration material. But gold foil was very expensive. Most of the time when I met patients who had gold foil restorations, they were pretty small, and they were areas where the patient had gone to a school, a dental school, or they had a friend who was going to dental school, and the dental student needed to place at least one gold foil restoration before they could graduate. Most of the time in private practice, the material that they were using was amalgam. And so if you see someone with a gold foil restoration or a gold onlay or something like that, it's probably someone who had a little bit of money at the time, and they were willing to splurge a little bit in order to get that sort of better material. But you don't see it that often. And whenever I do, they're always going to make this joke that that whoever, when they die, that whoever in their family is going to be able to sell those things, and they'll always tell you this joke. Just laugh along. It's important to them. Okay, so then here are what those gold restorations look like. Here you can see this is a full gold crown. This one right here is actually a 3/4 crown, and then this one is a gold onlay. And you guys, I'm sure, already learned the difference between an onlay and an inlay in your preclinic, but an onlay covers, it goes on the cusps, and an inlay goes inside the cusps. But anyway, um, down here in this radiograph now, without 100% being able to see the person's mouth at the same time that I see this, and this is not the same person here. These guys are not the same because this has a mesial aspect and a distal aspect to this onlay, and this does not have a distal aspect. So if they were trying to fool us here, then they aren't doing too good a job. But these areas at the top, these are probably amalgam. These ones at the bottom, these could very well be gold crowns. And I mean, this could very well be a gold inlay or onlay, sorry. We don't know without looking inside their mouth as well, which is why it's so important to be able to have the patient present at the time that we look at these, because I can't know while looking at this radiograph whether it's gold or whether it's stainless steel or whether it's a full metal crown. They're making a new one too, that's come out called cubic zirconia, which looks fairly similar to full metal. So then we also have stainless steel crowns. Now, stainless steel is still made of metal, right? Obviously, it's made of stainless steel, but it's not as dense as amalgam or gold. It's not um, as perfectly radiopaque as amalgam and gold. Sometimes with a stainless steel crown, you'll see a little margin right here at the bottom where you can kind of see through it just a little bit because x-rays are able to penetrate at least a tiny, tiny little bit through stainless steel whenever there's just that one surface to go through. Now here at the top, because it's a 3D object, right, we have to get through not only one layer of stainless steel, but also two. And so at that point, the second layer stops the X-ray photon from penetrating, right? And so here with a stainless steel crown, just keep in mind that the bottom, typically, a stainless steel crown, the margins are not made to contour to the tooth, so they're going to kind of stick out a little bit, and it's going to be smooth. It's going to look smooth, but that's because it's prefabricated. It's made before it ever even thought of going on a tooth. It's just made sort of in the shape of a tooth, and then when the dentist places it on a tooth, they don't actually contour it down to the tooth. It's meant to be a sort of temporary sort of crown, and it is meant more so for primary teeth, although sometimes you'll see it on permanent teeth as it's meant to be replaced in the future because we know these margins are terrible and it's going to cause a lot of bone loss. Like you can already see here, there's a bit of bone loss around this tooth. But it is a much cheaper option because it's already fabricated. The dentist probably already owns it, they could place a stainless steel crown on someone and not have to go through the whole process of taking an impression and then sending that to a lab and having to pay lab fees. And usually when you buy a crown or you get a crown done, the majority of the money you pay is actually the lab. They're very expensive, and so just keep that in mind when you're looking at something like this. If it has really terrible margins and you can see through a little section of it, it's probably stainless steel. Next up is a post and core restoration. Now, it's always done on an endodontically treated tooth, which means that tooth is having a root canal, where they're cleaning out the endodontist, not a well, sometimes regular dentists do it, but they're having a root canal placed where the dentist or whoever it is cleans out the pulp chamber of the tooth because there is an infection there, and then they place material down in there in order to preserve that area, right? So this bottom part right here you can see is not radiopaque. It's not as radiopaque, and you can see that this is more made of gutta percha. Okay, we'll talk about gutta percha in a while. And then the top part is this post. Now, it's going to appear radiopaque because it's usually made of metal. And so the post sticks down into that root canal, into the part of the treated tooth that it can fit into. And then the core refers to this section up here. So the post is this section down here, the post that sticks down in, like as if you were to put a post into the ground, right? Stick it down into the root. And then the core is what the crown of the tooth will sit on top of. A post and core is typically done when the cavity of the tooth has actually eaten away more of the tooth surface than is a good idea to place a crown on. Okay, so they place a post and core down into the tooth in order to give it more retention, to make it stronger. Because when you clean a tooth out, when you do a root canal, you take the blood supply away from that tooth, right? And while teeth aren't terribly high in living tissue, they do have some living tissue, and so when you remove that blood supply, you actually kill off what little remaining life there is to that tooth, and it becomes very brittle. And so, if you don't have a strong support for that tooth, then it could very easily break. And so, that is why a post and core would be placed on a tooth like this. On an x ray, this is what it looks like. Usually, there's a little section at the bottom where the post doesn't reach, and that gets filled in with gutta percha. And then there's the post here, and you can't really see it that well on this x ray because the crown, well, it's actually a bridge here, but the abutment for the bridge is actually placed over top of the core, but the core is actually sitting inside this crown, and then the crown portion goes over top of it. In this case, it's an abutment to the pontic and this abutment too. So next up is porcelain restorations. And remember we talked about porcelain being pretty dense and so therefore more radiopaque than other non-metal restorations. So the appearance of porcelain restoration is slightly radiopaque and resembles the radiopacity of dentin. So that's a really good way to kind of judge whether you think it's composite or you think it's porcelain. It's gonna look the same as the dentin. And so all porcelain crowns and bridges have a thin radiopaque line outlining the prepared tooth that represents cement that may be evident through the slightly radiopaque porcelain crown, right? So the area that they place to prep the tooth, they put that cement down inside because they have to glue the porcelain to the tooth, right? And so they place the cement down and then they place the porcelain on top of it. So when you see an all porcelain crown, it's going to look like dentin. So it's not going to be this bright white structure, but you'll see a very thin white line where the crown meets the prepared tooth. With a porcelain fused to metal crown, which we already sort of looked at, the metal component inside appears completely radiopaque. It's this perfect sort of perfectly round shaped metal blob in the middle, and then the porcelain component is this slightly less radiopaque area around that tooth, and we're going to see what those look like. First, we're going to talk about bridges though. So a traditional bridge is one or more pontics, a pontic meaning like the fake tooth, and it's held in place by crowns, which are also called abutments. Okay, then that's exactly what you're thinking of. Like there's the image we saw before where there was a crown abutment and there was a pontic in the middle, and then there was another one. It looks like two teeth, like the abutments, and then the bridge is like the pontic where you walk across the middle, right? A cantilever bridge is there is a pontic, but it's only supported by one abutment. So it's one fake tooth, and then it's only attached on one side. There is a Maryland bridge, which is the pontic. It's held in place by these little metal, or sometimes they're porcelain, little flaps or wings that stick out from the sides, and they're bonded to the two teeth that the pontic is in between. And then the implant supported bridge is when it's a bridge that's supported by an implant abutment instead of by that natural tooth abutment. Here are what some of those porcelain restorations look like. So here at the bottom, you can see this is a traditional bridge. There, this one is where one prepped tooth is. There's a pontic here in the middle, and then this is where the prepped tooth goes. There's a pontic in the middle, and then there's this other prepped tooth. This kind of looks like a face now. And then at the top here, we can see these are all porcelain crowns, fully porcelain crowns, because we can see there's not a lot of bright white, right? But then there's this perfect little white line right underneath that tooth where the crown of the porcelain portion, that cement that it has. I just have to draw another pupil. There we go. And then the cement, which is what is holding this porcelain crown to the prepped tooth. We see that a little bit better right here. You can see that perfect porcelain material, which is the same density pretty much as the dentin, and then it has this cement line underneath holding it onto the tooth. Here are what some of those bridges look like, but this one is the porcelain fused to metal. You can see inside here, this is metal, and the porcelain is just baked on the outside of the tooth. This is a little bit stronger than a fully porcelain crown, and so a lot of patients choose to do this because it is stronger. Maybe they grind their teeth or they clench, or there's some reason why they would prefer to have this. It's not as aesthetic, it's not as translucent as a fully porcelain crown would be, but that's okay because it's stronger. And so here you can see that this is a full metal crown of some kind, either gold or a different type of metal. And then here at the top, you can see these are porcelain fused to metal bridges. And it's actually all one bridge because it's all connected. But you can see this is an abutment, this is a pontic, an abutment, a pontic, and an abutment. And each one of these, you see this bright, bright white color in the middle, that's the metal, and then you see this sort of grayish color around, that is the porcelain that's baked onto the tooth. Same thing happens over here. So this is the metal portion, and then this area on the outside is that porcelain baked onto the outside. Here's a little bit better of what we were talking about when we talked about bridge restorations. So this Maryland bridge is when there's the fake tooth, this is the pontic, and then there's these little wings or attachments, right, that stick off of the side. And so they place that tooth there, and then they place some cement here, and they're going to bond it to the back side of these two teeth here. So then it just sort of holds on to those other teeth. Is that it has its pros and cons. So it's good because we don't have to prep these teeth. Like if they're perfectly fine, they don't have any cavities, then we don't need to shave off all of their enamel just to put a bridge on here. Okay, so that's an important aspect to it. But the con to this Maryland bridge is the fact that this is not nearly as well retained, which means it could easily fall off over having a traditional bridge. This cantilever bridge here in the middle, you can see that this tooth has been prepped. It doesn't look like a tooth anymore. It looks like a little stump. And the abutment is here. It's just the one, and it comes on. The pros for having a cantilever bridge is that you can actually place floss in this area and come up underneath this area, and so it's very easy to clean and take care of. The con for a cantilever bridge is that, again, it's not as strong. It's not as perfectly stable as a traditional bridge is, and when you place something like this, I mean, you guys have all been on like a seesaw, right? So if there's weight that comes down on this section, it will actually kind of uh, like tweak or twerk over here on this one. Like this side will actually come up a little bit, and it's going to cause that whole bridge to rock a little bit inside the mouth. If the pressure doesn't come down evenly at one time, it kind of comes down on the pontic side more so, then it will cause the bridge to rock, and it will put stress and strain on the abutment, and either that will cause it to come off, like maybe the cement will loosen and the whole bridge will fall off, or it will eventually cause this tooth to break. And then you'll have two fake teeth and you'll have to put abutments on these two. So it's, pros and cons. And then this one is the traditional bridge. The pro here being that it's very stable, it's very secure, right? We have two prep teeth on the outside here, and then we have the one pontic in the middle. The con to a traditional bridge is that it is very difficult to keep clean. So now all of a sudden, people who we have a hard time getting to floss already, now they have to kind of get this little stick and they have to like loop it underneath, and then they have to try to clean underneath a bridge, and it's not easy for patients who don't know how to do it, and they didn't go to hygiene school. So there's pros and cons to each one of these bridges. All right, let's get back to x-rays though. So composite restorations can vary. We talked about that already. Some composite materials, and every composite literally just means they put a bunch of things together. Okay, that's it. A composite isn't this one specific type or brand or any of that. There are many, many, many different brands of composite, and there is a wide spectrum of materials that a composite is made of. Okay, so keep that in mind. So some composites are very dense, and so they will show up radiopaque on a radiograph. But some composites are not as dense. In fact, they're not even as dense as tooth material. And so they will show up radiolucent on your radiographs. You might look at this radiograph here at the top, and you're going to take a quick glance at it, and you're gonna be like, "Ooh, they got cavities," right? That's not a cavity. We know, one, it's not a cavity because of the shape. It's this perfectly round shape. The cavities don't form like that, okay? But also, we know that we would know that this isn't a cavity because we would look inside our patient's mouth and we would see, oh, you have a white material here, right? So again, the reason we don't wait until our patient leaves before we interpret our images is because we need to be able to see that this is, in fact, just the kind of composite material that was placed that is radiolucent. This radiolucent material is actually an older sort of brand. It's an older version. So probably 30 or 40 years ago, when they first started coming out with composite materials, and they were more widely accepted, they were not as dense. They were not as strong. And so for the most part, the dentists would only place composite material on the anterior teeth because they don't need to be as strong. They don't have as much force of that loading strength that they have to have in order to chew up our food, right? So they would place restorations in the front because they were white and patients liked the way they looked, but they weren't strong enough for back teeth because they would just break off because they're not very dense here. And so for a very long time in dentistry, composite materials were always known for being anterior, and amalgam was always used in the posterior because it was considered stronger than composite material. And it was considered that composite material was not strong enough for posterior restorations. This is important because later, when we get to other classes, we're going to talk about um, the the insurance and how insurance can sometimes come up with our recommendations. And so sometimes, if any of you have worked in offices, the insurance company will only cover amalgam fillings for posterior teeth. They won't cover composite material, and composite is a little bit more expensive than amalgam. And so sometimes the patient has to pay out of pocket for the difference between an amalgam over I'm sorry, for a composite over an amalgam filling. And insurances only cover the old version because of that older mentality of composite fillings not being as strong. That's my robot vacuum again. Okay, so he's not as strong. I'm gonna turn him off. I'll be right back. Okay, so next up is acrylic. And when you think of acrylic, if especially, if you've ever gotten your nails done with acrylic nail, it is the exact same material. Okay, so an acrylic is when they take this sort of powder and they add this liquid to it that makes it form a shape, and then it hardens. And the acrylic is often used only as an interim or a temporary crown or filling because it is not very dense, but it's really quick and easy to apply. And especially if you've been an assistant or if you've ever had a crown placed, then you know what they do is when they prep a tooth for a crown, they shave off the enamel and they leave just sort of this little stump or post of the tooth that's left. It's just the dentin and then the pulp is inside there, right? So they shave it all down and then they have to take an impression and they have to send that impression to a lab. The lab will actually take maybe 2 or 3 weeks to make that crown. And what's that patient supposed to do in that 2 to 3 week time frame, right? Like what are they doing? They have a stump for a tooth. It's very sensitive. If air touches it, it's going to be very sensitive if they still have a nerve. And so what they do is they make a crown out of acrylic, and they place it in this thing, and then they put it in there and they shape it, and then this is actually something that assistants do because it's a temporary thing. And so the dentist will prep the tooth, they'll take the impression, they leave, and then the assistant will sit down and shape the acrylic temporary crown. They'll shape it, put it in there, make sure it looks good, make sure it's not too high. They'll shave it down if they need to, and then they place a temporary cement in there. They glue it in and they clean it up, and then the patient goes on about their day. That acrylic material actually helps to protect the tooth from being sensitive and from the teeth shifting around it, because if we didn't have that temporary crown on there, the other teeth might shift into that place. And then when the new crown comes in from the lab, the tooth no longer fits because the other teeth shifted. And so acrylic has a very good place in dentistry, but it is the least dense, and so it's not something that we use for for long-term use, right? You'll get a lot of patients who think their temporary crown is something that they can go years on, but that's not true. And on an X-ray, it's going to show up very radiolucent. Okay, it's barely even visible on a dental image. Okay, so we're also going to be talking about other materials that we might use in dentistry. So we talked a little bit about restorative dentistry. We're going to talk about endodontics. We'll talk about prosthodontics, orthodontics, and oral surgery, the different stuff that they place in there. Okay, so we talked about it a little bit when we talked about porcelain crowns, about base materials. And so, there is cement, which is one of the types of base materials, but there's others too. There's also sort of sedative sort of liners that they place underneath a filling in order to try to, soothe the tooth and make sure that it doesn't become inflamed. They use others to try to help insulate the tooth so that the filling material doesn't irritate the nerve. They have a lot of different types of materials, which you guys will learn about next term in dental materials. But as far as the radiograph stuff goes, we need to know that sometimes there are base materials that are placed underneath fillings, especially there's always a base material placed underneath the crown. And so we need to be aware that when we see a little bit of a difference between the crown or the filling and the tooth, we understand it's a base material. So they're used as cavity liners. They're placed on the floor of the cavity, prepared to protect the pulp. Sometimes they'll even have like a glass ionomer, which you guys will learn about, but it's like a fluoride releasing. But anyway, they appear radiopaque, less dense than amalgam. Okay, so when we talk about the base material, the liner that we use underneath a metal filling or an amalgam filling, then it's going to be less dense than the amalgam. So it's going to appear radiolucent, but it is radiopaque. Okay, so it's more radiopaque than porcelain, so it looks like a little white line, but it's not as dense as amalgam. So it's still a radiopaque structure though, okay? Don't get that confused. And then metallic pins are often used underneath amalgam fillings or even composite fillings, and they're just there to enhance retention or help to hold that filling in place a little bit better. They can appear as cylindrical or screw shaped, depending on what they are. But they're also radiopaque. So here in the top left, you can see that base material that's placed underneath the amalgam. That is just a liner. Sometimes it's called a cavity liner. There's a lot of different companies that make these. So, whatever company you guys like or whoever your dentist likes to use, that's on them. I remember I always used a Vitrabond. My dentist was all about Vitrabond and how it was a liner that they placed under fillings, and it had a fluoride releasing component to it, so it helped to soothe the tooth. But anyway, um, this upper right image here has a metallic pin. This is a metallic pin placed underneath a composite filling. So this is a fairly large composite filling. You can see here how it covers almost all of the tooth. And then there's this little metallic pin right there underneath it. This just helps to hold on that composite to the tooth a little bit better. And then on this bottom image, you can see it's a metallic pin on number 30. It's right there. So up next is gutta percha. Gutta percha is what is used in endodontics or root canals, right? A root canal treated tooth has gutta percha placed inside those pulp canals. And gutta percha is a clay-like material. If you've ever played with one of these things, these gutta percha points, they're actually really cool. They're like a little squishy, but they're clay-like material used that you stick down into the pulp canal once the pulp canal has been completely cleaned out, and they appear on an image radiopaque, similar to the base materials, but it's not as dense as metallic restorations, which we saw when we looked at that post and core. Remember how the gutta percha was not as dense or as radiopaque as the post and core was, and so that's what this whole section down here looks like. Okay, so next up is a silver point. Now, a silver point is something that's no longer used in endodontics. If you work for a very older dentist, they probably remember placing these, but it is not something that's used very often anymore. But that doesn't mean you won't see it on a radiograph, right? Because patients could have had these types of restorations placed in the past. Silver points are basically these little, they look just like gutta percha. They're these little sort of rods of silver, and they're placed down in the pulp canal. They're more radiopaque. They look just like the amalgam or the metal, because obviously they're metal, and they're gonna, it says, appear more radiodense than gutta percha. Radiodense meaning they're more radiopaque, right? They're brighter white than gutta percha. For a long time, they were used alone before gutta percha came out, and then once gutta percha came out, dentists started using them together. The problem with silver points is that they corrode over time, right? Silver obviously has ionizing, it not ionizing. What is it? It erodes, right? It turns into rust when exposed to moisture, and so or it tarnishes as well, and so it was very inflammatory to the tooth. The tooth was not very happy with these silver points. So you'll hear a lot of patients talk about how, someone had a root canal and then they had to turn around and have the tooth pulled. Well, it's possible that they had it placed with silver points instead of gutta percha because of the way that they are. And then the other thing is with silver points, because they're more firm, they were easier to place down into those root canals. They went down in really easily, but because you're able to sort of push and you were able to actually puncture through where the apical region was and down into the bone without knowingly doing that, without having any more of that tactile sensitivity. So they were very hard to seal the tooth off from the surrounding structures when you used silver. So it's, again, not something we use anymore, but it's something that you might see on your boards, and so it's something that we have to talk about. And it was done for a long time. All right, next up is prosthodontics, materials that are used in prosthodontics. And these are going to include complete dentures and removable partial dentures. These are things that should be taken out of the mouth before you take your radiograph, right? We don't need to see these on our images. Um, they're going to obscure and obstruct our field of vision for the things we want to see. So what we need to see is the bone level. We need to see the teeth that are still present. We need to see those kinds of things. When you take an image with complete dentures in there, um, it's going to give us the illusion of teeth that are floating or they don't have roots, obviously, because they don't. And then if we take an image with a removable partial denture, usually it has a metal base and then it has like these little acrylic, they're called saddles, but they're like the little ridge that sits over the alveolar ridge. Um, and it's going to appear radiopaque where the metal is present, and it's going to appear slightly radiopaque in the areas where that acrylic is. But either way, we're not going to be able to see the bone or the teeth that we are trying to look at. And here's what those look like. See how these teeth are kind of just floating? They don't have roots. And then the bottom, you can see that patient has those teeth there, but it looks like they didn't have the patient stand up straight. And that is why we have this sort of white blob right here, right? Because the tube head, as it went around the back of that patient's head, actually bumped into the back of their head, back of their neck. And so this is someone who didn't stand up straight inside this panoramic, and also they didn't remove their full upper denture. Now, sometimes you might have the patient leave this in so that you get that bite, you get the patient into the focal trough better. You're going to hear a lot of people who talk about that and how, sometimes it's a good idea to leave maybe one part of the denture in while you take an image of something else. When you take a panoramic, you need to have them take all of it out, okay? All of it. If you were taking maybe a couple of PAs on these lower anterior teeth here, you might have that patient leave the upper denture in so that when they bite down, they hold the receptor in like they should, but not for a panoramic, okay? This is what it looks like when you don't have your patient take out their partial dentures. So here, this metal frame is what we're looking at, and it sort of wraps around some of these areas. In the back here, you can see there are like these little sort of wings that reach out and hold on. These are the saddles that the book was talking about. And you can see that these teeth don't look like they have roots. In the anterior here, it does look like those patients has roots, and then in the lower as well, it looks like they have some of those teeth. But there's just this metal frame that's completely obscuring our vision of those teeth. Also, again, it looks like they didn't have this patient stand up straight when they were going into this image, and so it therefore bumped into the back of their neck. This is actually really common for older individuals, especially if they are missing a bunch of teeth, they have dentures or partial dentures. They're probably a little older, hopefully, fingers crossed, and yeah, so they probably have a harder time standing up straight. And so this is a very common error for panoramics on older individuals, but still an error. Moving on to orthodontics. So orthodontists put a lot of random stuff inside people's mouths. Their braces here, you can see these are pretty common. You can see this is a lingual bar. Well, hopefully it's lingual, right? We don't know for sure because it's two-dimensional. Anyway, usually these are placed on the lingual. And there's other things too, like palatal expanders. There's spacers, space maintainers, all sorts of things that orthodontists are going to put into your patient's mouths. And so this is another key reason why we do not let our patient leave, or we have our patient sitting there with us while we look at these images, because these are pretty normal. These are very common things. You're going to see these on your x-rays and you'll be like, oh yeah, that's what that is. But the orthodontist is going to put things in your patient's mouth where you have never seen that before. You have no idea what the heck that is. And unless you have your patient sitting right there and can have them open and look at it and see, be like, hey, what did you do here? What is this? Why is this here? Um, then you have no idea what that thing is. It happens a lot, actually. I would say probably once a year, I would see something that was weird, that I hadn't been exposed to before, that an orthodontist was doing. That I mean, they'll do whatever it takes to get those teeth where they need them to be. And I mean, I don't have a degree in orthodontics, so some of those things to me were completely new because I'd only been exposed to braces and lingual bars. But palatal expanders look really funny on X-rays, and then space maintainers look kind of funny, not as weird. It looks just like a band and a bar. But yeah, you're going to see a lot of random things. Usually anything metal, obviously, is going to be very radiopaque, very radiodense. And if it's not metal, sometimes they'll put like these little blue sort of blobs of material on the occlusal surface of patients' teeth, and it's to help prevent them from biting down all the way and knocking a bracket off. And so you'll see those. Those won't appear quite as radiodense or radiopaque. They'll be a little bit more radiolucent. So materials used in oral surgery. Now, implants are being used with increased frequency. Oral surgeons are not the only ones licensed in Texas to place or implants. Also, periodontists are allowed to place implants. Even general dentists are allowed to place implants. Now, it depends on the dentist and how comfortable they feel with doing that. Would I recommend going to a general dentist to have an implant placed? I don't know. It would definitely depend on the individual. Some general dentists are amazing at certain things. They didn't specialize, but they should have. Like some of them are amazing at root canals, and so getting your general dentist they just have a natural talent for some things, and every dentist is a little different. So maybe you work for a dentist who's just amazing at placing implants, and then yeah, go to them. But anyway, not only the oral surgeon is allowed to place them. Other people are allowed to place implants, but a lot of oral surgeons place implants, especially in areas where things are kind of weird. If it's close to the maxillary sinus or there's other complications, a lot of times a general dentist or even the periodontist won't feel comfortable placing it. They'll send them to the oral surgeon. A lot of times as well, if you have to have a tooth removed and then place an implant right after, then they'll go to the oral surgeon instead of trying to do that more complicated procedure with a different specialist or with the general. Um, Implants are being used with increased frequency. That's absolutely true. A lot of our patients have implants. The appearance varies based on the shape and the design of the implant used. Now, your patients think that all of the implants are the same, and that is not true. There are many different types of implants. There are many different brands, and each brand has their own shape and their design. They have different sizes. They have different retention techniques. Some of them are even using different materials, and so where you go to get your implant placed is going to be important that you keep track of that information, and then you're able to give them a call later and have information given to you, because you know 10 years 12 years later, when you have a question about maybe having that implant replaced, or you need a new crown on that implant, or what have you, you have access to the information that you needed. Oral surgeons also place suture wires, metallic splints and plates, bone screws, stabilizing arches are used in oral surgery to stabilize fractures of the maxilla and the mandible, and we'll talk about that. But some patients have oral surgery where they actually have their mandible moved, right? Like maybe they have a very severe class 2 or they have a severe class 3, and they cosmetically go to an oral surgeon, have that surgery done in order to move the mandible where they want it, and then we'll see things like this as well. So these are images that your book has for implants. So this is what an implant looks like before a crown, or the abutment and the crown are placed on top, and then this is what the implant looks like once the crown is fully on there. You can't really see it that well in this one, but every implant has these little spaces in them, and so every implant forms this like little face, and they all look like really happy. And I love implants because I'm always like, look how happy your implant is, and patients, I don't know, they seem to get a kick out of it. They probably don't. They probably think I'm ridiculous. All right, so this is a panoramic where we can see wire mesh. You can see that up here. These are wire mesh. And then plate is actually these little sort of circular things, these things right here. These are the plates. And then the screws are the little lines you see sticking out of it. And those are the difference between what a plate and a screw look like on a panoramic. Here again, we can see the metal plate and the screws on the panoramic. All right, so we're going to talk about other things. So we see a lot of other things on our images, right? So first up is jewelry. We see a lot of jewelry, earrings, necklaces, nose jewelry, especially. We can even see, nose jewelry sometimes on our intraoral, and we'll see eyeglasses. Sometimes we'll see the napkin chain on our images, depending on, how slouched our patient is sitting, or if we left the napkin on the patient while we took our panoramic. Sometimes we'll hear hearing aid, or we'll see hearing aids on our images, and then sometimes we will see even shrapnel on our images. So again, this is what that jewelry looks like. Metal earrings are going to appear very radio dense. And sometimes on our panoramic, we'll see ghost images. So this is where the image should be. And then you can see here, this is that ghost image where there's no earring right here, but it certainly looks like there is, right? But I mean, hopefully that patient doesn't have an earring sticking inside their mouth, but you never know. So these images can obscure important information and render the image non-diagnostic. And necklaces and nose jewelry can also be seen on a panoramic. So other objects we might see would be eyeglasses. You might just see the bottom portion of the frame of their eyeglasses. You might just see the bottom portion of it on maybe an intraoral, but obviously on a panoramic, if they don't take their glasses off, then you're definitely going to see the whole thing. Sometimes you'll see the napkin chain when you take a panoramic. You wouldn't see that on an intraoral. A hearing aid, sometimes they'll have metal components inside the hearing aid, and they should remove it. If your patient has a cochlear implant, obviously you won't have them take off the whole thing, but there is a certain section, where they can take that off. And then there is shrapnel as well. So sometimes the patient has been exposed to shrapnel of some kind, and they were injured, and so part of that metal is left inside. It's up to the patient and their doctor to determine whether or not that shrapnel was worth removing at the time, or maybe it was more, it's not harming them, so maybe they just leave it in there, and that's okay. And so if you see something like that, it's a great time to ask your patient, like, hey, what's going on with this? Like, what happened here? It is okay to ask your patient, what happened here? Now, should you ask, how many people they lost in Vietnam? No, you should not ask that question. But you should ask, what is this thing I'm seeing on your x-ray? Like, this is something, this shrapnel is obscuring an image that I need to see. Is this something you can remove? Like, what happened here? What is this? They don't need to tell you the story of how they got hurt, or how it came to be there, but they do need to tell you, oh yeah, that's shrapnel. That's what that is. I can't take that out. So you need to have that conversation with your patients, but you need to be mindful that you don't overstep your bounds there. All right, so this one right here, this is our eyeglasses. Right here we can see on an intraoral image for our anterior PAs. And then this one here, this is probably a nose ring. Nothing wrong with nose rings, but you got to take them out. Okay, if you have questions, please let me know. These references are in APA 6.